is Professor Sandeep Bishna. He is a professor of cardiology at the All India Institute of Medical Science, New Delhi. He did his DM in cardiology from AIMS and his fellowship in interventional cardiology from the Washington Hospital Center in USA. He also is a past editor of the Indian Heart Journal and has been a guest editor of the Catheterization and Cardiovascular Interventional Journal. He is also the former chairman of the National Interventional Council of the Cardiological Society of India. He has a illustrious career. He is also the course director for TCT India, Eurochorus and SIM. And he has actually more than 200 manuscripts, abstracts and chapters to his credit and has developed several orations. I would like to invite him to talk to us about non-STEMI, when to intervene. Over to you, Professor Sandeep.
Hello everybody. Today I am going to talk about NSTEMI, when to intervene. So I think the when to intervene means two things. Number one is the need to intervene, and then if we have to intervene, the timing to intervene. So coming to need to intervene, we have to decide whether it is a NSTEMI, the diagnosis is secure or not. Then second, we have to decide whether it is a high risk case or a low risk case or an intermediate risk case. And the risks can be of two types. It could be a ischemic risk or it could be a high bleeding risk. The other thing that we need to look at is the cause of NSTEMI. Now coming to the second part, we have to decide if we have to intervene, when to intervene, whether we have to intervene immediately or we have to intervene within 24 hours or beyond 24 hours. So to bring out these points, what I will do is I will show you some real cases and then I think these points will come out very nicely. So the cases that I am going to show will be ACS or not ACS but low risk, high risk ACS, a case where delayed invasive strategy is used, and then ACS with high bleeding risk. So coming to my first case, he's a 59-year-old male, hypertensive, hyperlipidemic, who developed and whose known case of coronary artery disease developed chest pain suddenly while seated at home, and the pain lasted for several hours. Pain was of throbbing type, intensity 9/10, substernal variety associated with nausea, diaphoresis, dyspnea, and interestingly radiated to left leg but not radiating to arm or jaw. Patient had this for about an hour, and then it went away, and then it returned after 3 hours. By this time, patient was brought to casualty. He became disoriented and confused. So, friends, what is the differential diagnosis at this point of time? So, just based on pain, we cannot decide very much. We have these following differentials in mind: coronary artery disease, aortic dissection, pericarditis, pneumonia, pulmonary embolism, and some other differential diagnosis which we can see. So I think important point at this point of time is to discriminate whether this chest pain is a typical chest pain of coronary disease or it is an atypical type of chest pain. So what will help decide the type of chest pain? Number one, the quality of pain. Number two, the tempo and the progression. Number three, the presence of risk factors. And then whether it gets relieved with NTG or rest or by GI medications. At the same time, we have to realize that some of the chest pains always present atypically. For example, in people who are older, women, those who have diabetes mellitus, or those who have past history of heart failure. Now, coming to type of chest pain, we see that this chest pain has got several typical features. For example, it is a highly intense pain. It is of sudden onset. It is associated with nausea, diaphoresis and dyspnea, and is also substernal location. The abruptness of the pain is very important. As I said, it arises suddenly. At the same time, there are a number of risk factors that are present. Older age, male sex, hypertension, hyperlipidemia, and already known case of coronary artery disease. However, at the same time, we have to understand that there are some perplexing features as well. Number one is that it is a throbbing kind of chest pain. We know that coronary pain is for visceral type pressing kind of chest pain. Also, the pain is radiating to left leg, but not to his arms or jaw. So these are two very features which are generally not associated with coronary artery disease. So where does this take us? Let us look at his general physical condition. Patient is afebrile. Heart rate 62 per minute. Interestingly, blood pressure is low, 96/47 in right upper limb. But other things are okay. Respiratory rate, saturation is 100%. The only things that are abnormal are the glucose is 121, the creatinine is elevated 1.7, and CK and CKMB values and troponin values are also raised. So I think these are the important findings in the evaluation of the patient. If you look at ECG, we find that it is practically normal sinus rhythms, sinus bradycardia, but there are symmetric T-wave inversions seen in lead V3 to V6. X-ray is not very relevant. There is some tortuosity in the aorta. That's all. So now let us analyze what we know as yet. We definitely know it is not pneumothorax based on the X-ray. We also know that this is not a left or right-sided failure. Absence of pericardial rub makes pericarditis very unlikely. But at the same time, we have to understand that there are some missing data as well. Most important missing data is that the blood pressure is not measured in both arms and also the leg. And I think that is important. Other thing is that we have not done positional maneuvers to exclude pericarditis, which anyway probably is unlikely. The worrisome aspect is that there is hypotension. ECG seems typical of myocardial ischemia, and cardiac biomarkers are also elevated. The other point is creatinine, which is mildly elevated, and which brings us to the question whether it is related to shock. But the shock is not long. Patient seems not to be in shock, at least, except the blood pressure. And the other possibility is that there could be ischemic insult to the kidney. So now how do we reason? The most likely diagnosis is, of course, acute coronary syndrome. But at the same time, you have to understand that some additional data is still needed. Why it is important to have a confirmed diagnosis of ACS? Because we wanted to start unfractionated heparin, and if suppose it is a case of aortic dissection, it can be very harmful. Anyway, where the patient was there in the primary center, because the cardiac biomarkers were elevated, the repeat ECG showed some resolution of T-wave inversion. They thought it is acute coronary syndrome, definitely NSTEACS. Some fluids were also started to bring up the blood pressure, which really increased after this fluid administration, and the chest pain also resolved, and therefore they thought, and therefore the diagnosis of NSTEMI seems secure, and heparin drip was started, and because patient was NSTEMI and higher risk because of elevation of biomarkers, ECG, and also the typical pain, etc., age, etc., with multiple risk factors, the patient was referred to our center with the diagnosis of NSTEMI based on dynamic ECG changes, increased cardiac biomarkers. So once the patient presented to our center, by that time the chest pain again recurred. We noticed blood pressure in the left upper limb was 172/86, which was not only normal but was high. Also interestingly, we found that there was a crescendo-decrescendo murmur 3/6, systolic murmur in the right upper sternal border and left lower sternal border, and also a decrescendo diastolic murmur at the left lower sternal border. Plus, we also found that there was subtle left-sided facial weakness and 4x strength in the left upper and lower extremities. Speech was consistent with expressive aphasia. Now, although the troponin was elevated and things were continuing, but we were not secure with the diagnosis. And what we thought was that there was a diastolic murmur, which makes the possibility of proximal aortic arch dissection very much likely. Plus, there were some neurological findings also, and kidney findings also. And we know that if there are simultaneous ischemia in several vascular territories, diagnosis of ACS is an incomplete explanation. It seems like that it could be aortic dissection. Also, the murmur, although it was a ejection systolic murmur and not holosystolic murmur, which would be expected in complication of acute coronary syndrome, mechanical complication. So it looks like that there's not a mechanical complication of acute coronary syndrome. And based on all these findings, we decided that there was a higher possibility. And also, remember, the leg pain was there, which could be because of dissection, of aortic dissection extending to the iliacs. So we decided to stop the unfractionated heparin drip immediately and send the patient for CT angio, despite slightly abnormal creatinine, because we thought it was a case where we needed a definitive diagnosis to proceed any further. Now, 3 hours later, patient started having chest pain, and we could actually document that there were 2 blood pressure readings different in both the limbs, which are mentioned, and CT angio revealed an extensive complex Stanford type of type A aortic dissection extending from aortic root right up to beyond renal arteries into the common iliac arteries. So clearly it was a case of acute dissection with severe AR, and it required emergent surgical repair, which was done, and then patient was sent to rehabilitation to recover from embolic episodes. So we can see now that case of acute coronary syndrome has got many differentials, and it is very important to consider these differential diagnoses and rule out differential diagnosis before we can start definitive treatment for acute coronary syndrome. Actually, type A aortic dissection can present in 26% of cases like ACS. So I think we move on to our next case, which is a 56-year-old active smoker with complaint of central chest pain, awakening from sleep, which did not relieve with NSTEACS, and patient continued to have chest pain, but it was also not relieved by NTG when patient presented to our hospital. Patient was hypertensive with bronchial asthma. It was in mild distress, but otherwise he was okay. Based on ECG, you can see ECG, there was some changes, and troponin T was also elevated. We made a diagnosis of ACS this time, and we started with aspirin, clopidogrel, and unfractionated heparin. With this treatment, the ECG also resolved and biomarkers came down. Now the question is what to do about this patient. And as discussed, it is important to establish whether the patient is high risk or low risk. And there are 2 kinds of scorings available. The GRACE scoring on the left side shows predicts mortality in 6 months, 12 months mortality in these patients. On the other hand, TIMI score actually predicts the cardiac events in next 30 days. And these are the TIMI factors that need to be considered. And if you consider these factors, if you look at TIMI score, it is found that these correlate very nicely with early mortality, and varying from 4.7% to 41% in the TIMI score 7. Here, the patient had only less than 3 risk factors, and patient also had, although patient had ECG elevation, ECG changes and biomarker elevation, so puts him in stage TIMI score 2, which is a low risk patient, as you can see, and therefore we know that TIMI score can help guide management because it predicts all-cause mortality, new or recurrent MI, and severe recurrent ischemia requiring revascularization in the hospital or early during the course of NSTEMI. So based on that, because the patient is low risk, we know that if there is a low risk patient, we can follow the conservative strategy or that is ischemia guided or ischemia directed therapy. On the other hand, tactics TIMI 18 trial shows that if it is a yellow colored intermediate risk or a red colored high risk patient, then early invasive interventions show significant decrease in death, non-fatal MI, and rehospitalization. So definitely in intermediate plus minus, but at least in high risk group, definitely early invasive management helps. Here, since as I already said, risk score is only 2, therefore conservative strategy can be adopted. So what is the conservative strategy? We give aspirin, 325 milligram, clopidogrel or ticagrelor. Generally prefer clopidogrel in this situation. Sublingual anti-G to be given every 5 minutes till the pain is relieved. If it is not relieved, then continuous IV anti-G can also be given. Unfractionated heparin bolus is generally given and then followed by continuous infusion. Alternatively, enoxaparin or fondaparinux is also a good idea in this case. Beta blocker have to be started within 24 hours if no contraindication. ACE inhibitors should also be started if ejection fraction is less than 40%, hypertension, diabetes or CKD. High intensity statins should be started, continued for at least 1 year. But how to follow these patients in hospital? Do serial ECG changes, measure troponin. If serial ECG changes show further worsening and dynamic changes and troponin further increase, maybe we have to take this patient for an invasive strategy. If not, that at the end of before discharge, you can subject the patient for stress testing, and if stress testing comes positive, then we can go for delayed invasive strategy. If it continues to be negative, then optimal medical therapy. Here, low risk patient was managed with optical medical therapy because before discharge stress test was negative. So this brings up to my third case, which is a 42-year-old female presented with sudden onset chest pain, 1 hour duration, with heaviness referring to neck and jaw, also associated with mild shortness of breath and nausea. In past, she had been having these intermittent chest pains, which were relieved by rest. Omeprazole was given also, suspecting the GI disease, but there was no relief. She had a history of receiving the oral contraceptive pills. The family history, there was no CAD or sudden cardiac death. She had work-related stress, a lot of bulk-related stress. Vitals were stable. GVP was not raised. Other things were okay. So now, in this patient, again, we have 3 differential diagnoses. ACS seems most likely because chest pain is highly suggestive of a plaque rupture, heaviness, onset disappearance with rest, not responding to omeprazole, and lasting for 1 hour duration makes it very likely for ACS. GERD possible but not likely because the pain is heaviness, not burning, not related to, it is related to exertion, not improved by omeprazole. Lastly, it could be a pulmonary thromboembolism.
I think due to time constraint, and we have to stop the symposium there. I'm so sorry to announce that. And because next speaker is waiting, for the completeness sake, I think we can allow 2 questions. And if you all have any questions from the audience, I think it's time to now forward. Then I think speakers, Dr. Saman and Dr. Sandeep Mishra, they're waiting. So it's time to ask some questions.
I would like to ask a question from Professor Saman. Can you hear me? Professor Saman? Hello?
Yes, I can hear you.
Yes. Professor, you said you would recommend dual antiplatelet treatment for more than 1 year for certain category of patients. So what kind of patient do you recommend? What sort of high-risk patients do you recommend for long-term dual antiplatelet for more than 1 year?
Yeah, so we go by the Pegasus trial here. So patients with diabetes, previous ACS, multi-vessel disease, over age 65, or chronic kidney disease. And if they have 2 of those 5 criteria, we would consider long-term therapy after assessing their bleeding risk. In those patients, we would follow Pegasus criteria and give 60 of ticagrelor. If patients have peripheral vascular disease, then we would consider giving 2.5 milligrams BD of rivaroxaban.
in addition to those, considering the coronary complexity of the procedure, do you recommend long-term dual antiplatelet treatment? Suppose now if it is left main bifurcation, or you don't recommend?
So not on that basis, Roshan, simply because the modern, let's say, third generation stents now are all relatively safe to give short duration of antiplatelet therapy. So for left mains, I don't give extended therapy. Now, if you're going to give, let's say, full metal jacket, then you may wish to extend therapy. But I think that should be based on a individual patient basis. But left mains per se, we don't extend therapy anymore because of the third generation stents are so good.
More questions? One more question. Can I take the chance? Professor Samal, greeting from Colombo. And can you hear me?
Yes, I can. Thank you.
Yeah, so this you're talking about this liver anticoagulant agents like rivaroxaban and apixaban. And do you recommend these agents for all the high-risk patients, or do you recommend these agents for patients with acute coronary syndrome and atrial fibrillation?
Yeah, so at the full dose, it is only of anticoagulation. It is for those patients in atrial fibrillation and acute coronary syndromes where, once again, based on bleeding risk, you might wish to put them on full dose anticoagulant and just one antiplatelet for up to 12 months and then stop the antiplatelet. The low dose rivaroxaban that I was referring to is only for the acute coronary syndrome patients at high risk of ischemic events, and particularly those with peripheral vascular disease, because the COMPASS study showed that low-dose rivaroxaban was particularly effective at reducing major adverse limb events.
Thank you.
I'd like to thank all our three speakers for such an informative and very good lectures that they gave us. But in interest of time, we have to move on, even though we would have liked to ask more questions. I'd like to thank all three speakers on behalf of the Ceylon College of Cardiology. Thank you.